Hello, thanks for coming to today's video where we're going to be discussing bronchiectasis. So as always, we'll begin with a simple definition of bronchiectasis. So simply put, bronchiectasis is an irreversible airway dilation. And when we talk about airway dilation, we're not talking about the bronchioles or the alveoli, we're talking about some of the larger airways. When you get to alveoli and bronchioles, you're talking more about emphysema. So we're not talking about that. So what causes airway dilation? Well, primarily it's going to be due to a weakness in the wall. And because you have a weakness in the wall, not only does it dilate easily, but it also collapses easily. So you get kind of both of these occurring at the same time. Now, what causes this weak wall? Chronic inflammation. So anything that can cause chronic inflammation in those airways can eventually lead to bronchiectasis. And not only chronic inflammation, but you also get plugged with mucus plug. So, and when you get a mucus plug, that doesn't allow the body to be able to, or the lungs especially, to remove some of the debris and the bacteria that might get caught in these airways, and so they'll accumulate and eventually cause, the infection, which will cause the chronic inflammation, which will lead to the weak wall that easily collapses and dilates. So, when you think of bronchiectasis, you definitely want to think of these three features. These are the main features. So let's go through the pathogenesis. I've kind of developed my own, the way I kind of consider it. The way I consider it is a cycle. And so the first part of the cycle is you get some sort of destruction to the airways. And of course, the most common cause of destruction to this airways is going to be inflammation, chronic inflammation. So once you get this destruction, obviously you're going to destroy some of the walls of the airway, and so that can lead to impairment. And when we talk about impairment, what we're talking about mostly is the ability to clear things out of your lungs. Primarily, it decreases the mucociliary clearance. And so mucociliary clearance is just your lungs' ability, in the bronchus and the larger airways, to kind of have that cilia beating upwards and cleaning out the lungs in a consistent fashion, slow but consistent fashion. And so what happens if you can't clear out all the debris and bacteria? Well, you'll get infection. And so chronic infection is the key here. That's usually what's going to be causing most of these problems. So when you get infection, what does that do? That leads to destruction. Destruction leads to impairment. Impairment again leads to infection, and infection leads to destruction. So you get this kind of vicious cycle that produces. So it kind of goes round and round. Now, if this occurs one time, you're able to clear it out, that's not an issue. Bronchiectasis occurs when this occurs often, over and over again in a chronic fashion. So that's kind of what you want to think of when you're talking about bronchiectasis. Now, what I want to switch my mode to now is just talking about some of the causes. So when discussing the causes, what I'll do is I'll just talk about where in the cycle do each cause kind of begin, because this can occur, this can start in the destruction area, in the impairment area, or the infection area. So let's begin with infection. So again, it's not just a single time infection, but it has to be a chronic recurrent infection that will lead to bronchiectasis. And that occurs most commonly in immunodeficient states. So this can be anything from HIV, chronic variable immunodeficiency, or even SCID, DiGeorge Syndrome, which is a T-cell deficiency, and even chronic granulomatous disease. And of course, we can go on and on and on. And all of these will cause infection. And not only infection, but recurrent infection. And so by having recurrent infection, you're just kind of continuing the cycle over and over and over again, eventually leading to the bronchiectasis. Now, before I finish this, there are also some specific, because here earlier we just talked about some conditions that can cause any sort of infection, but there are some specific pathogens which have been known to lead to bronchiectasis. One of them being Pertussis, that whooping cough, so maybe that strong cough kind of causes damage to the airway. You have measles as well that can cause it. Adenovirus, TB, and Mycobacterium avium complex, which is just like another, TB and Mycobacterium are both mycobacteriums, but MAC is more common in HIV patients. And finally, you can get the fungal infection, which is the allergic bronchopulmonary aspergillosis, which is caused by the fungus aspergillus. So pretty much infection, that's what's going to cause it, and that'll tip off the cycle. Next, what we can talk about over here with impairment. So we're talking about different conditions that can lead to impairment of the mucociliary clearance. The main one, the number one, is going to be cystic fibrosis. This is actually the most common cause of bronchiectasis in the developed world. Beyond that, you also have primary ciliary dyskinesia, where the cilia isn't able to beat, and so of course you're not going to get the mucociliary clearance that you need if you can't, your cilia isn't working. And this is very commonly associated with DiGeorge syndrome. So kind of want to remember that condition as well and its association with bronchiectasis. Finally, beyond just related to the cilia, you can have muscular dystrophy. Muscular dystrophies affect the diaphragm, and so you're not able to breathe in and out and get that airway cleared out. And so even if you can beat upwards, you're not able to clear anything out. So that can also lead to this impairment, infection, and destruction. So these were all conditions that were congenital. So let me write that up here. So these were all kind of congenital conditions related to the cilia and the ability to clear. Another type of condition that can occur is obstruction. So what happens in obstruction is, okay, so you might be able to beat the cilia upwards, but if the actual airway is constricted, you're not able to, your substances you're trying to remove or the pathogen or debris you're trying to remove gets blocked. So obstruction, doesn't affect the cilia, but the cilia kind of has to work against this blockage that's above. And so what are conditions that can cause it? First of all, the congenital malasias and stenosis, such as tracheomalacia and tracheal stenosis. These are one. The other thing can be foreign body. So someone swallows something. Patient swallows a foreign body. Obviously, if you have a foreign body there, even if the cilia is working, it's not going to be able to get whatever substance it is around that foreign body. And finally, mucoid impaction. So mucus getting stuck can prevent clearance of the lungs. So that is all the different causes of impairments. And finally, we can talk about things that destroy primarily. So of course, both of these, both impairment and infection will eventually lead to destruction. But we're going to talk about conditions where destruction is the primary source. So these are going to be your connective tissue disorders. So that includes your SLE, sarcoidosis. It includes Marfan as well. That's another cause, and even inflammatory bowel disease. So like Crohn's and ulcerative colitis. So those are all associated with bronchiectasis. So now that we've talked about that, let's kind of talk about the airways here a little bit more. And so what we'll talk about first is how the airway actually looks. So as you can see, up here we have a normal airway. So you can see here's the normal airway, and this is an airway that has bronchiectasis. Now, one of the first things that you'll notice is the diameter of the normal airway. So if you see, I'm highlighting the diameter of the normal airway there, and then let's look at the diameter of the abnormal airway. So the first thing you notice is this airway's diameter is much smaller than the diameter here. So that's one of the first things that you notice is that dilated airway. We've already kind of mentioned that. So what you also want to look at is the thickness of the two airways there. So in the normal it's very thin, whereas here it's much thicker. So that's another thing to keep in mind. So let's write this down. First, you have a widened airway. Secondly, you have a thick wall, and thirdly, you have mucus. And so you can see, down there's a lot of mucus here where there's no mucus there. So those are your three features of the actual airway. So now let's look at the lungs here. Now, depending on where the dilation occurs, that kind of can give you a hint at the etiology. So in the upper airway, for example, this is more commonly associated with cystic fibrosis and sarcoidosis. So that's something anecdotal to remember. The middle airway, you get the primary ciliary dyskinesia. So that would be kind of DiGeorge syndrome there. And in the lower airway, we're going to be you'll find more of the pneumonias. Now, what's very interesting is if it happens in the central airway right there, that's going to be your allergic bronchopulmonary aspergillosis. So those are kind of just little quick things to kind of remember there. So now that we've talked about that, let's kind of switch focus into the clinical aspect. So clinically, what will you find? Well, what you'll have is you'll have a patient who has complaining of a chronic daily cough. So he just has this cough and he can't stop. and it's producing sputum. So it's not just a dry cough, which might be associated with GERD or something like that. No, this is a cough with sputum, and if you do CT finding, you'll have some positive findings of bronchiectasis, which we'll go into. So if you have these three, a chronic cough with sputum and positive CT findings, that's pretty much diagnostic of bronchiectasis. So again, when you want to think of bronchiectasis, the typical patient will complain of this chronic cough with sputum. So keep that in mind. Now, what happens is, they have this kind of low-level cough that's always there, and then every once in a while they'll get these episodic exacerbations. So it'll suddenly get worse suddenly, and during these exacerbations, the cough will be worse. There'll be more sputum production. They can get severe fever, chest pain, and they can even have dyspnea. So these exacerbations, probably associated with some type of infection, or the cycle just kind of repeating itself. But it's very classic of a patient with bronchiectasis. So a chronic cough and with productive cough, which every once in a while gets worse, and they feel better. Now, once the patient has it for a long time, they can get fatigue, and again, this is a late finding, and this is correlated with the forced expiratory volume in 1 second. So FEV1 will be lower in these patients, and the lower it is, they tend to have worse fatigue. Now, another unique finding here is hemoptysis. So again, very few things that cause hemoptysis. Bronchiectasis is one of them, and this just occurs because you get erosion of the airway near a vessel. So you get kind of erode into a vessel, and then that vessel, obviously leaks into the airways, and then you end up coughing blood. So that's a finding there. Now, cyanosis can occur. However, this is usually found in children, and they can have severe hypoxemia. So that's something to watch out for. And usually this is due to some, ventilation perfusion mismatch. So, they might be, they might have perfusion of blood going to a certain area of the airway, but no air, or vice versa. And this eventually can lead to pulmonary hypertension. And of course, pulmonary hypertension for a long period of time leads to cor pulmonale, which is right heart failure. So that's kind of the cyanosis there. So finally, what would you find on physical examination? Crackles are present about 74% of the time. Wheeze, 22% of the time. And clubbing is actually fairly rare. You're going to get it 22% of the time. So those are things to keep in mind on physical examination. Of course, crackles and wheezes will be upon auscultation. Now, how would you evaluate a patient? One of the first things that you want to do is do an X-ray. And so what I'll do is, let me put up an X-ray here. So here we have an X-ray. And so what are the findings that are commonly seen on X-ray? So let's zoom this in. So the first thing that I want to point you towards is, here we have what's called so you can see these two lines here going out this way. This is due to the thickened airway wall, and this is called the tram track appearance. So this tram track, although it's kind of hard to see sometimes, it signifies bronchiectasis. And what you also might get is you get this cystic dilation. So if you look closely, you kind of got these little circles here. That cystic dilation is also very typical of a patient with bronchiectasis. Now, or cystic dilation, as we can call it as well. Now, X-ray are good as an initial step to kind of suggest bronchiectasis, but high-resolution CT is, imaging of choice. So HRCTs, high-resolution CT, so it's imaging of choice. So here we have a CT scan of a patient who has bronchiectasis. So let's kind of zoom in here. So what will you find? One of the first things that you'll find is you kind of get these enlarged alveoli. Now these alveoli are not supposed to be that large. So let's write here, airway dilation. I'm sorry, I didn't mean alveoli, I meant the airway, excuse me. So the airway should not be that large, but you can see in this case it is. And so that's a sign of bronchiectasis. And you can also see wall thickening right here. This is called the signet ring appearance. And so this is due to wall thickening. So CT, as you can tell, is much more definitive than chest X-ray, because you can very clearly see that. So that's going to be your imaging. Let's talk about lab. One of the first things you want to do is you want to do CBC with differentials, and that's because they might be having an infection at that moment, and that's something you want to diagnose. You also want to check the immunoglobulin levels, so IgG, IgA, IgM, because remember, immunodeficiency is a common cause of bronchiectasis, and so you want to see if it's, if that's the case, and that can show up with low immunoglobulin count. Next, you also, the most common cause, you want to rule it out, cystic fibrosis. So that you look for the CFTR mutation analysis. You just want to make sure that maybe they don't have underlying cystic fibrosis. You do want to do sputum culture and smear, so that you can kind of do sensitivity and all that stuff. So most commonly you get either some sort of bacteria, or mycobacteria, or some type of fungi like we talked about, Aspergillus. So after the lab, the other thing that you might want to do is to check the severity of it and kind of confirm the diagnosis. PFT, so pulmonary function test. And so of course this is an obstructive disease, so you're going to get the obstructive findings. And so in the pulmonary function test, your FVC will be normal or low. Your FEV1 is going to be very low, and so your FEV1 over FVC ratio will also be very low. So those are your kind of pulmonary function test findings that you need to be aware of. And finally, that kind of pretty much sums up evaluation. Let's go on to treatment. So your treatment, of course, this is a chronic condition, so you'll be dealing with the patient for a long time. What are your overall goals? One of the first things, so we'll talk about goals here. One of the first things you want to do is you want to control infection, because infection can lead to an exacerbation. So a lot of times prophylactic medications given, antibiotics are given. Secondly, you want to decrease inflammation. Again, inflammation is one of that triad, and you want to increase bronchial hygiene, which obviously is disrupted when you have poor ciliary movement. So as you can tell, your goals are kind of to hit all those three triads that we talked about here. Let's talk about that. So as you can tell, we want to limit inflammation, we want to cut out the infection, and we want to the bronchial hygiene, which is compromised because of the decrease in mucociliary clearance. So our goals are pretty much to fight all those three three parts of the cycle. So the best way to actually treat bronchiectasis is perhaps treat the underlying cause, because remember, bronchiectasis has a variety of different causes. So if you can treat the underlying cause, it makes it, you can kind of thwart the bronchiectasis. So if they have TB, give them chemo. If they have immunodeficiency, depending on which one, you give them treatments such as maybe IVIG. If they have allergic bronchopulmonary aspergillosis, you can give them steroids and antifungals and just treat that underlying condition. And of course, if they have rheumatoid arthritis or sarcoidosis, you can kind of use those autoimmune or immunosuppressants. So the second thing is when they get an exacerbation, first thing you want to do is you want to try to prevent an exacerbation. So this is first done by macrolides prophylactically given, and so you give these to patients who have recurrent exacerbations, and they say the mechanism of action is it inhibits Pseudomonas, especially the film of Pseudomonas. So this has been used, and it has been shown results in limiting that Pseudomonas. What's also tried sometimes, because of course macrolide has systemic side effects, you can use an inhaled antibiotic. And so these are just aerosol antibiotics. However, the only problem is these can cause bronchospasm. So the first time that they take it, it has to be under supervision. And so if they have bronchospasm, then basically you just prescribe albuterol. They should just take that before they inhale that antibiotic. And so again, it's fairly new. Still more studies need to be done, but that's kind of one way the direction is moving. Next, you want to increase that bronchial hygiene. So that can be done by using some type of mucolytic or airway hydration. So by doing that, you can kind of keep that airway clean and prevent that cycle from continuing. And so generally this is done with some type of nebulized hypertonic saline solution. And so this should be saline, sorry, 1 second. Saline solution. And so that can help keep that airway clean and prevent infection. You could do some chest physiotherapy. This can be something like a directed cough or forced expiration, which again kind of keeps the airway clean, or it can be the PEP, the positive expiratory flow device and the oscillatory PEP as well. So these are kind of some devices that are used. And finally, you do want to make sure that they're vaccinated, such as a pneumococcal vaccine, and that can help prevent that recurrence of infections. So this is how you prevent an exacerbation. How do you treat an exacerbation? That's going to be different. So treatment of exacerbation usually is caused by an infection that's suddenly gotten worse. So of course you're going to want to give antibiotics. Which antibiotic do you give? Well, it's going to be culture guided, and that's because generally these patients have been on prophylactic antibiotics, so the bacteria develop resistance. What are the common pathogens that are associated with it? These can be H. influenzae, common, Moraxella catarrhalis, Staph aureus, not as common, but we still need to mention it, and even strep pneumonia, not as common, but does need to be mentioned. And Pseudomonas is probably the worst one there. That's the one that's very life-threatening. So those are kind of what you want to target when you're giving the antibiotics. Now, this can be treated on an outpatient basis or an inpatient basis. So we'll talk about both those. So you can if the patient is pretty stable and afebrile, you can just give them some antibiotics to take home. However, if they have a high respiratory rate, if they're breathing, which is greater than 25 breaths per minute, if they have hypoxemia, if they're becoming hypotensive, or if their temperature is greater than 38 degrees Celsius, then you want to go ahead and admit them. This is much more serious. You're probably thinking Pseudomonas here. So outpatient, which antibiotic do you want to give? You can start with the fluoroquinolone, but you definitely want to culture and do sensitivity, and whatever that sensitivity tells you, you want to maybe change the antibiotic after that. But inpatient, you definitely want to start with anti-pseudomonals because that's the most serious one, and then guide by culture. So inpatient, outpatient, you're going to be treating them slightly differently. Now, finally, let's talk about the surgical option. So a lot of times surgery is done, if it's focal, you can do a resection of that area which has bronchiectasis. If it's more generalized, then you probably need to replace the whole lung. So you do an entire lung transplant. And finally, you want to do surgery if there is severe hemoptysis. So if a patient has severe hemoptysis, they're coughing up a lot of blood and becoming hypotensive, then you just do surgery, find the vessel that's bleeding, and then occlude it, cauter it, and just prevent that blood loss. So hope you enjoyed the video. That's all for this topic, and I'll see you guys in a future video. Thanks.